Welcome to H&HN Daily. I'm Susanna Hopsollen, Senior Editor for Hospitals and Health Networks magazine. 45% of healthcare costs are driven by 3 to 5% of the community. This presents an opportunity for providers to be proactive, to intervene early and deliver the best care possible at the lowest cost. Today, I'm joined by John Glaser, CEO Health Services, Siemens Healthcare in Malvern, Pennsylvania, and Steve Linn, Chief Medical Officer and Vice President of Academic Affairs, Inspira Health Network in Vineland, New Jersey, to discuss population health and care management, taking on risk and improving outcomes. Welcome, John and Steve. Thanks for joining us today.
Thank you. It's nice to be here.
How do you define the population for your care management strategy?
You have to determine which group of individuals you're going to hold yourself accountable for. It could be a community, it could be a payer, it could be a disease population like your CHF patients or people undergoing a particular type of surgery. The key is actually to make sure that definition is clear and that you have a way to access which patients you're going to be monitoring, and then develop care strategies to try to improve the health of that population at the lowest necessary cost.
Why is it important to stratify patients in risk categories, and how does that change for that particular patient over time?
It's important to stratify because of resources. There are certain high-risk patients that consume an incredible amount of the cost of healthcare, the total dollar amount of healthcare, and you have to determine what resources you're going to need to manage that patient population more efficiently. You can't devote the same resources in aggressively trying to do patient-centered medical homes or other types of intensive medical programs to all patients. You've got to focus your resources efficiently, and that's where risk stratification becomes so important.
Are there specific data elements that you use to stratify those patients?
There are specific data elements, and we're getting smarter all the time about what pieces of data those are. But you can imagine that some of them have to deal with to what degree there's a supportive family structure that can help, to what degree the patient is cognitively in good shape, to what degree there's a large versus small number of other diseases or comorbidities coming on. There are a wide variety of variables. I think we're progressively gaining understanding about those stratification sets of data and how good they are at being predictive.
I think John touches on a very important point, in that some of the data elements that we've historically used in healthcare have ignored key aspects that are critical determinants of health, like a recent loss of a job, death of a spouse, or other change in environment that may not have seemed part of the health system, but is intricately tied to someone's health status and their ability to follow a treatment plan and take their medications and do all the things that we need them to do to stay healthy.
What are the key technologies that we use to support the new care models?
One is the electronic health record, very foundational. The ability to capture a patient's data to support the caregivers they engage in care-related activities, ordering prescriptions, retrieving results, documenting care, et cetera. The second would be the health information exchange, which enables the exchange of data between providers and between electronic health records. The third is a series of analytics that allow one to assess to what degree costs are improving or quality is becoming better, and to do various cohorts or sub-cohorts within that. The fourth is a wide variety of technologies that are directed to people who use mobile devices and attachments to mobile devices, which increasingly bring information to them, allow them to sort of really understand and be on top of their healthcare activities.
Part of decreasing healthcare costs is decreasing utilization. What steps can a hospital take to accomplish this?
Well, I think one can tackle the general question of appropriateness of utilization through two general means with the IT. One is just analysis that says here's the rate of utilization by different types of patients, by physicians, et cetera. So you can take a look at, we have overprescribing or over-radiology utilization, or at least apparent that might go on. So that's one part. The second part is you can have logic within the computer system that if a radiology procedure is ordered, the computer can come back and say, wait a minute, there was one just done, or given the clinical indications that the patient appears to have, this may not be the appropriate modality to go off and do this. And increasingly, for example, as we get into understanding of your genome and mine, the machine might say that particular regime is most effective if the following genetic markers are present. Are they? Or run the tests, et cetera. So you can both analyze utilization, but also guide utilization through the technology.
For many providers, patient engagement is really the stumbling block. How do you involve the patient in the care team?
That is the $64,000 question. And I think the biggest concern physicians have about being held accountable for all these things related to population health is, what about the role of the patient? Patients can be motivated to change their behavior and be engaged, but it's going to require a different approach by the physician and the care team to get them to take responsibility for their own health, or to at least be engaged, as you say, in what actions they're taking and how they can take steps to improve their own health.
Are we using technology to improve the feedback loop with the patient?
It's not as if the lack of technology or understanding of this, that, and the other. Frankly, look at the obesity challenge. It's not lost on anybody. The scale works, and information exists about calories in this and calories in that. And so I think, there are clearly examples where we got the technology and you got the information, but something is not quite connecting there. So I think technology can help, but I think we should not be naive about believing that that's really the answer to all this.
The scale works, as John pointed out. But there are very effective tools that help people to stop smoking. That does not need to be physician-driven. It could be another member of the care team. There are currently strategies in place where, when that's identified that that patient is perhaps motivated to quit, rather than spend any more time with the physician, they quickly stop that visit and have them intervene with a behavioral health specialist who's much more skilled in that intervention.
Should the hospital CEO have a population health scorecard, and what should be on it?
Hospitals are more and more being asked by the government and their communities to look at the community's health, and not just the people that may be visiting the hospital, but that town or that city, and what the hospital is doing to partner with the community to try to change some of those metrics. It is not something that we have had to measure in the past.
Thanks for joining us today.
Our pleasure.
Thank you. Our pleasure.